welcome to HealthSpaces Almost Live. A central thing every year at HealthSpaces is we always typically kick off with a state of the industry discussion. We're going to do that again here, just virtually. And it's always typically a highlight of the program because we bring together diverse roster of healthcare systems to really talk and set the stage for the program to talk about where things are. So we've got an awesome panel lined up here today, but I'm going to hand it off to our moderator, who's Rob Moss from ERDMAN. ERDMAN's been a wonderful supporter for HealthSpaces over the years, and we're going to be talking, the theme for this event is Embrace the Great Reset and looking to the future, 2021 and beyond. And no better person and organization to moderate this discussion than Rob Moss and ERDMAN, because they focus on strategic planning and they're always looking 5-10 years out. So I'm going to hand it to Rob, and he'll introduce, take the session from here. And then I'll come back at the very end to say it's time to wrap up. But I'll leave you guys to have a provocative and insightful conversation. And thank you, Rob.
Yeah, thank you, Michael. As we kick off here, I'd like to ask our panelists to do a brief introduction. So I'm going to start in order on the screen. And so, Rick, you're first up. You could,
Hi, nice to be here. Rick Redetzke, System Vice President of Facilities and Real Estate for SSM Health based in St. Louis, Missouri. We have 23 hospitals across 4 states.
Brian?
Hello, everyone. This is Brian Weldy with HCA. I'm the Vice President of Engineering and Facility Management, and we operate 184 hospitals and 2,000 different sites of care. Look forward to being part of the discussion today.
Awesome. And Jeff?
Hello, I'm Jeff Land. I serve as Senior Vice President of National Real Estate Services for CommonSpirit Health. We're headquartered in Chicago. We operate about 140 hospitals across 21 states and about 1,000 points of care.
Excellent. Thanks, everyone. For those of you tuning in, we'd love to be an interactive session. We do have an open chat as well as a couple of poll questions. So monitor that throughout our presentation. But just before we start, I'd like to offer a few opening comments. We entered 2020 with a lot of trends in healthcare already in motion. Focus around cost of care, emergence of value-based reimbursement, a shift from acute services towards looking at lower cost settings and ambulatory care. Also, an increased focus on consumerism and a weather eye towards disruptors entering the marketplace, creating new competitive challenges. And certainly COVID-19 accelerated and shifted many of these trends, but certainly bent the adoption for health and work from home by almost a decade. So as we talk today on the state of healthcare and facilities, we'll talk about current impact, but we also want to future considerations that Rick, Brian, and Jeff are experiencing and what they're planning for. And really around 3 key discussion areas. The first is around telehealth, and we've all seen the across the country tenfold increase in virtual encounters. And so what's that impact look like on our real estate planning? Also, work from home. We've had numbers of health systems having up to 65% of their administrative staff working from home. And so what does that do to the ancillary spaces that we manage and have in our portfolios? And certainly both of these have had an impact on real estate planning and capital planning. And so understanding that, how as we enter into sort of a new phase of things, what does that look like? What are key considerations around future planning? So to kick this off, I'd like to ask Jeff a little bit about some of the assumptions that your organization is planning around the percentage of services being delivered through their virtual health service.
Oh, thanks, Robert. I think CommonSpirit is not so much looking to a percentage, but looking at the ways that we will need to be delivering care models differently and how to align with those. Clearly, the consolidation of care models around having physicians who can spend part of their day on telehealth and part of their day seeing patients physically changes the footprint for us. And how exactly, I'm not sure of that yet, but I do know we have teams together looking at exactly that. I would expect over time to see consolidation of the number of exam rooms per physician. So I would expect that to go down slightly. And I would also see us changing sort of the configuration of space differently to allow for at least a tenfold increase in our televisits.
Excellent. Rick, maybe share from SSM's perspective what you're seeing and planning around this issue.
Yeah, to address your question specifically, I think it's an interesting one, what percentage of our services, but I look back at one of our clinics, and it was a medium-sized clinic, and we were probably throwing darts at the wall at the time we were in development on this thing in the April timeframe, so during our first wave, if you will. And we made assumptions of 25% for primary care and 10% for specialty. But I think, that's an N of one, because everything that you're doing is an individual project in a special market with all of the business plan and pro forma thinking that goes into it. You can't probably generalize for 5 minutes. The other thing, that I'm thinking about with telehealth is, I don't know that it's really a telehealth or in-person visit type of answer. It's really maybe additive, and thinking about telehealth as a means to improve health and provide access and really engagement with our patients. And sort of everybody's going to be doing it. And it's going to be a vital aspect of how we engage with our patients versus, how many exam rooms do I not have to build in the market? So.
And Brian, from your perspective, what will have significance on your real estate planning?
We have a team here dedicated just to telehealth. As a vice president's over that, and I'm sure that team, and I've heard of the just exponential growth of their involvement. It has to cover a couple of things. It's your practice, the technology, and how do you adopt that within a large organization like HCA. I think we look at telehealth twofold. The first is that it augments care, augmentation of the care that we already give. So, for example, for inpatient care and other aspects, it complements, in other words, how care is delivered to your existing infrastructure. But that does change your existing infrastructure business as well. We did a huge rollout with that with our urgent care centers. We have over 100 of those locations across the country. And so that was a strong technology presence for them as well. So we know it was here. We've talked about it a lot. COVID threw us into the middle of accelerating that drastically. And I think most of us have seen that. I think as a positive change, now it's going to be about seeing how does it impact the real estate piece down the road. I mean, telehealth is one component. You still have to see patients. You still have to deal with things that become acute. And if anything, this will help provide a better way of care for our facilities, but it will impact our real estate in some fashion.
Robert, could I just add other modalities of care? Because I think it's not just about, I think as Rick said, the percentage of visits. Just a week ago, we announced a partnership with a behavioral health remote service to be added into primary care and to be operated from these same locations. I think we start looking at other things like that, plus remote monitoring becoming a much bigger issue, and acute care from home also needing a place to work from. So this consolidation of not only just primary care and even specialty care, but rather it's a totality of how to manage the patient more effectively.
Right. Absolutely. Great feedback. Again, one of the other topics that we've been chatting about working from home. And maybe, Brian, I'll start with you here and talk about maybe the impact that you've been taking in your staff, maybe some of the other considerations that COVID has brought forward.
Well, the first question to ask or think about is what kind of job types can work from home? Are you an office support role or business support role? And that seems to have opened up dramatically. Obviously, some cases you have to have the care directly with a patient, so there's not a work from home strategy with that, of course. But as you think about the whole work from home piece, a lot of people are figuring that out here in Nashville. So it's a lot of it is community based, is how fast are each of our communities opening up, to what extent are they opening up, and then sort of what is the perception of the workforce around that whole idea. And what we found is that while Well, we've opened the doors up to, social distancing, masking, and all the things that we've had safeguards in place. Still, people are tending to work from home more and not come in as much as we thought that they might. For example, I'm in a building of about 500 people, and on a daily basis, we may have 50 to 60 people that have badged in. So it still hasn't been figured out what that's going to be. But if you were to ask me where I think it might be going, I think it was already happening before COVID, as far as you could walk around a space and notice it was empty quite often, and it became more obvious to work from home. I think there's easily 20 to 30% space reduction as far as having a person assigned to a space. So what that means is that you have spaces that can be shared by others, and from that sharing, you can reduce your footprint or bring in other departments and consolidate some of your space. The big question is going to be, how do we deal with the real estate that's now not being utilized as we kind of bring space into the core? So that's yet to be determined how to repurpose that space, but that is a big question that we have.
Awesome, Jeff. From Common's perspective.
From our view, we had an initiative going prior to COVID, as most did. Brian said it very well. A lot of the spaces were underutilized historically. We're really looking for sort of a 3-to-1, if you will, one workspace sort of relationship to 3 individuals. So let's say that our target overall over this next 18 months is reducing our administrative space by about 60 to 65%. That's underway today. And in our case, I guess you could say some of our leases, for example, were either coming to an end or were close enough to the end to where we were simply able to restructure them. In other cases, consolidations will mean negotiating with landlords. In other cases, we are selling excess real estate. So we do see this aggressively happening, and it's already working. I think our current occupancy in these offices right now today, of course, in the middle of a work from home order, is in the high single digits. So maybe 8% of our workforce is coming in every day. And we don't anticipate that going over 30, 35% on a steady state.
Excellent. Rick, from SSM?
I think very similar experiences. I mean, most people are working from home most of the time. We've certainly done the thing with revenue cycle and other office support roles that can be effective in working from home. They're now set up with technology to enable that to happen on a permanent basis. We always had intentions, separate from COVID, to begin a master planning exercise for what's our long-term administrative footprint. We're spread across many buildings. All of them we lease, and over the next 3 to 4 years, those leases are coming due. We're certainly not going to have anywhere near the footprint that we have today. Fitting in between what Jeff and Brian said, my kind of thumb in the air is probably 50% of the square footage that we have today we'll have in the future. To me, it's a heck of a social experiment that we're going through right now to try to figure out, what 2 months or 2 years from now looks like. I think over the next year, a lot is going to be figured out. But, this idea of working remote a lot of the time, you start to lose those human interactions. And how do you build trust with team members that you never met before? So right now, many of us are working with the same people we've always worked with. But as time goes by and your constituents on your team change and you've never worked with them face to face, that dynamic will be much different. So that's how we're thinking about it.
I'll add one comment too, as well, as far as the work from home and how we deal with technology to connect to our colleagues. As I was just speaking, you may have heard my phone or my computer ring. That was my boss chiming in. So I've noticed that my boss has a lot better access to me at any time of the day. So, all this technology connects us all the time, doesn't it?
It certainly does.
Let me add one too. It's interesting in the design or redesign of workspaces. One of the things that's really important is this concept of, the old concept of caves and commons, the idea that how will we bring people together periodically and then separate them again for a period of time to avoid the sort of isolation that Rick is talking about. So many of our remodels, as we look at these new space designs, have a much larger conference rooms and common spaces and gathering spaces and meeting spaces in them.
That's great. Great impact. So, as we were thinking about, all this, those two topics, obviously, what I'm hearing is that a lot of planning was already underway. Things were what we had as an event accelerated and our efforts to not only from a virtual health and perspective, but that work from home. When we reflect back on the last 7 months, and as we look forward 1, maybe even 2 years, how has real estate planning and capital planning been impacted? Maybe you could share a little bit of the story of what you're working through as an organization to reprioritize. We've heard of organizations that are really focused more on horizontal capabilities across the system to deliver more virtual care at home and focusing on that investment versus straight into real estate and capital projects. But you guys have large portfolios, diverse portfolios. I'm just to hear your capital has been impacted, and maybe I'll ask Rick to get this one off.
Sure, thanks. Certainly there's, I would say, cost pressures that continue, and capital's a component of thinking through that. I like to say, we need to really just simplify and reduce the cost of our real estate portfolio in any way possible. So there's a lot of legacy real estate, whether we own it or lease it through some integration that happened, that type of thing. So some of our capital, frankly, is sort of, I'll call it ground up, thinking about our individual market that we might have, where we have multiple locations that could be more effectively delivering care by combining those locations and getting out of operational leases. And with that, of course, you're doing all the traditional things about better patient experience and staff experience and the branding of your organization by having a new access point that's combining maybe several access points that were legacy, if you will, in your portfolio. Another big commitment of capital on our part is to be really purposeful with facility infrastructure. So we now have a dedicated capital pool that's focused on things and spending money on things that most people don't get a chance to see in our mechanical spaces and above ceilings and building enclosure stuff, but also using some of those dollars to do things that fall into physical security. So short of having more security officers, you're doing physical security projects. Energy efficiency, so spending facility infrastructure dollars on energy efficiency projects. Some great ROIs, of course, with retro commissioning and LEDs and things like that. When I say all that, our organization coming on the heels of just spending over $500 million on a replacement for an academic medical center. And that over the last 10 years, I think 6 of our hospitals have been completely replaced with a greenfield new hospital. I don't think that's our core investment going forward, that we're going to be investing a ton of dollars in new capacity for inpatient settings, perhaps some replacements, but that's how we're seeing our capital right now.
Excellent. Jeff, what's going on from your perspective?
Well, it's hard to even know where to start, right? We entered sort of a bit of a crisis over the cash crisis over a period of many months where revenues were definitely impacted across the industry. And we responded to that. There were a number of projects we decided to slow or stall for a period of time, which allowed us to sort of re-envision how to spend it in the future. And that's really what's going on right now. When you talk about the next couple of years and leading to the next 5 to 10, I do think we'll continue, as our mission would have us do, find ways to tread lighter in some areas and heavier in others. So if you've seen one geography, you've seen another. They're all different. They're all unique. And one thing that I would say is consistent within our mission is the ability to reach those that are underserved. And so I do see us reaching much farther out with remote monitoring, with telemedicine, with the ability to reach more people on a broader base and more geographies further out. And so I would say if we were emphasizing one thing, I don't think it's inconsistent with what Rick was talking about, and that is that we're likely to spend more on technology. We're likely to spend more time and money on lighter and faster and smaller venues, at the same time making sure that infrastructure is not ignored.
Yeah, and I think what we're seeing from the poll here around the uncertainty as a result of COVID-19 associated economic cost your organization to rethink the capital project. We're seeing across the votes there that between 88% yes and significant along that line. Brian, how's your organization modifying or planning efforts?
Well, all of us went into response mode. At HCA, it's kind of like figuring out what do we do with our existing facilities to respond to the pandemic. And then when we look at our project spend, we hit the brakes pretty hard on any new starts. And we continued on with our projects that were already underway in various phases with actually, breaking ground and moving forward. Then we've actually lightened off the brakes a bit, and we are now starting to resume those projects and picking those back up again. Even in the facility reinvestment infrastructure piece of us replacing roofs or boilers, et cetera, we tightened it up for a little bit, but now we're reinvesting in those things as well. We find that really in the capital investment space, it's best to have a better consistent spend because those things age over time, and we kind of know what our needs are and try to continue to keep those facilities running. It all ties to reliability, energy efficiency. So we actually released some energy efficiency projects here just recently. So as far as the major construction projects that are going to be rolling forward, I think we're looking at that very systematically, somewhat cautiously, but knowing that we have to invest in infrastructure in some way going forward, even as community care potentially expands and other things that happen that we're seeing, there needs to be a placement of capital to grow the services we provide.
Excellent. We had a question from the chat from Elizabeth Vaughn, and I may have missed it timing wise, but I'll read it out to the panelists here and let you guys react to it. In addition to office/overhead space reduction, how are you seeing telemedicine reducing your need for clinical space and teaching space? Anybody want to tackle that first?
Let me give a shot at that. First of all, we have training centers across the country for HCA. So actually, in some respects, we were already using remote technology to connect to experts to teach the students in their areas. There is some advantage of bringing in students together in a way to learn, and then they can connect virtually with an instructor anywhere in the country in our company. So we were doing that to a certain extent already, and it'll probably continue to expand that way. As far as how it will reduce our future of square footage, that's a great question. I don't really know right now where that's going to play out. One can assume that healthcare companies are going to have to figure out that they're going to have some extra real estate, but how much it's going to be and how telemedicine will specifically impact that, for us, it's just too early to know.
Jeff, Rick, any thoughts from your perspective?
I guess I would
No,
say,
just one.
Go ahead.
Sorry, Jeff. Just one comment that, there's other levers, if you will, that play into the square footage and the need for facilities that arguably are even more important than this telemedicine equation. One of the metrics we like to talk about when we're looking at an opportunity to do something in a market is, what's the number of patients we're seeing per room per day? And when you do that math, many times you say, well, we have 100 exam rooms and we saw 250 patients today. Well, that's 250 patients over 100 rooms. That's 2.5 patients per room per day. And, you don't have to be an industrial engineer to say that just doesn't feel efficient. So there's all of these types of things that are in play when you're considering any individual opportunity, or even just thinking broadly on the strategy, just really trying to be effective and efficient with the assets that we do have. That is not to diminish the potential role that telemedicine is going to play in transforming us, but on a day-to-day basis and opportunity by opportunity, sort of consider it as one component.
Excellent. Jeff?
I guess I'll just amplify what I said earlier, the idea of combining other services within primary care spaces like like remote monitoring and behavioral health and other things together with the telemedicine to balance it out and look at using combining exam rooms and even office space in a same space, in the same way that we just completed a medical office building in a hospital complex in China, where they are very commonly doing that, putting the doctor in and the office space in the exam space area. There are a lot of things we just don't know about how the models of healthcare will change. And last but not least, the retail face on healthcare, whether it's Walmart or a number of Amazon and others who are getting into it and literally putting primary care, whether it's in their parking lot or in a corner of their big box. Those things, I believe, will also impact and change the way we do healthcare and, frankly, make it more efficient than it is today.
Good. We have another question from the chat. Maybe we'll look at this. And this is Jonathan Hunley. How are you all identifying and prioritizing the infrastructure needs across your health? Brian, you want to start there?
Yeah, I'll start off with that, sure. So there are several factors that go into prioritization. First of all, there's a sort of facility DFM, Director of Facility Manager, identified need. With that, we have divisional engineers that go out and walk the facility and verify their project list and their priority. Several things weigh into that analysis. First of all, age of equipment, condition, how well it was maintained, what areas of service, is it an area of critical service that's important? How would an outage of that particular system impact business continuity, safety? So there's a grid that we use to sort of balance all that out and say, okay, here's a facility score, here's a project score, and then we compare those scores to each facility within a division. So one of the things you have in a challenge you have in a large organization is, of course, being a facility manager myself at a few hospitals over the years, your projects are the most important, right? So how do you compete that with everyone else? So we have regionalized an engineer that's looking at all of their projects and trying to do an assessment of what is really servicing up to the top as the highest priority. They validate that with our division leadership team. Eventually, that gets into a list that helps to prioritize that. As you can imagine, I think probably everyone on the call today and many of you listening that oversee facilities, I'm sure you have more project infrastructure needs than the budget will allow to support. So it does take a good leadership style of DFMs to sit down and figure out what does I really need to do, what's the most important, and to give senior management at your hospital options so they can decide, okay, what does it have to do now, what can wait, and what's the right strategy. So it's very much a collaborative process to get to that right prioritization model.
Just to add on to that, much different scale that we have at SSM, smaller. It is in some respects boiled down to a glorified spreadsheet. And I know there's tools out there that will utilize more effectively long term. But like Brian said, it's the safety factors and the things that can impact the environment of care. Are you designing to an N or an N+1? What kind of redundancy do you have? I think ultimately, as you prioritize, I always like to get the local folks that are managing that individual facility to force rank their projects, not too much different than what Brian articulated. So their force ranking is a good starting point, but you're looking at ROI as well. I think our next level is to tie our CMMS work order data. Number of times we're doing things on a shutdown, scheduled or unscheduled, working that into the analysis. The other thing we do is we have, I guess, 3 buckets. The biggest bucket I'll call plant operations. The other 2 are being physical security and facility appearance projects, for lack of a better term. Pretty tough to compare some finish upgrades to your chiller replacement or that type of work. So we break it up into 3 buckets. Each one of them has a different sort of way to force rank the priorities. I like to say that our facilities team can be Switzerland in thinking about those projects objectively and trying to quantitatively rank them as much as possible versus maybe an administrator at a local facility saying they have the worst waiting room in the entire system, and then dealing with those politics. If you can say, well, here's our tool, we've actually ranked all of the waiting rooms in our system, you've got a score of 78 out of 100, so you're probably a year away from being replaced on a prioritization list. So that's how we tackle it.
Maybe a couple of nuances for us would be being a relatively new system now, coming up on we'll have 2 years in February. Being together with two large systems, we completed a facility condition assessment for every facility across CommonSpirit Health, and then prioritized them over this next 10-year period, laying them into a capital program that would cover infrastructure according to very much the same as far as Brian explained. We do score it. We do, obviously, at the very worst end of the scale, it's something that is either would have to do with business continuity or would have to do with regulatory requirement we're not meeting or something like that, all the way to the wish list and the case of the normals on the other end. And so those things are laid in, and then a little bit easier perhaps than what I heard. We have all facility related personnel do report up through and to the National Real Estate Organization. And so we have a partnership with the local facility, but it is a discussion that we must agree upon as to what will be done in what order.
Excellent. Well, we have a few more questions in here, but I also want to leave time some conclusion thought. One of the questions in the chat is, what are you seeing in terms of shifting towards patient-centric operating hours and provision of services versus the traditional provider-centric model? Anybody want to take a run at that one?
Can you rerun the question?
Yeah,
you're cutting out a little bit. If you can.
Okay, I've been monitoring the chat, and I'm trying to sit as close to the mic as possible. Essentially, here, it's about the shift to patient-centric hours and provision of services versus the traditional provider-centric model.
I think that ship sailed. I don't know. Maybe that's oversimplified, but I think our patients have figured out that they're going to run this. They're going to tell us when they want something done. And in the last few years, it would appear that there are others willing to provide it on those times and in those ways. And so I think we're affected by both the generations as they come, millennials being different than others and so on, in how they relate to technology, how they relate to human interaction and touch, everything from the drone delivery of medicine to doorsteps to putting literally nurse practitioners in cars and having them line up with emergency responders to keep them out of the ED and set bones in the living room. We are talking about a different world. And so from my view, I think that retailization and in every aspect, I'm not seeing a provider-centric model unless we literally have a doctor who is so good that and some are, that people are willing to do whatever to see them. So I don't know.
That's a great segue. I wanted to reserve some time towards the end of our time here to gain each of your perspective on, again, realizing that we do not have a crystal ball, but getting your perspective on the future. Where do we see the industry and the future of healthcare facilities in a 10-year period of time?
Well, I'll start more or less sort of as a shout out to what's coming later in the program. I know that Dan Stanek is going to talk a lot about the future of consumerism healthcare. So I say that because where things are going in the virtual health realm, I think there's going to be some great talk about that. Also, later on, Ron Galloway will be talking about the future of healthcare and see how that plays out. So the future, though, a thought of how to look at the future maybe is more than it is what the future will be. And that is, a thought is around, you've heard these two terms a lot, resiliency and agility, right? Well, those really are truly strategies. And the way they're strategies is we've been implementing resiliency right now a lot. We're trying to look at how to reduce costs, how to make sure we have the relevancy of care to our patients. I've always thought it was interesting when the topic comes up that, we had to dial back on elective surgeries. But I think all of us know that nobody wants to go in for surgery. It's not very elective. You have to do those things eventually. So, but those aspects of care will continue. But my point is resiliency to the care of patients. But the other area is agility, and that really is our strategy, and that is how are we going to move to these new things quickly, that as things unfold, do we have an organization that's prepared to do that? Can we turn on a dime? Do we have a lot of overhead to make that change? And those organizations and us, and those of us on the call today that are part of those organizations, how are we contributing to helping organizations be agile during those new discoveries and being someone that can help facilitate that change?
Rick.
Well, I just think our buildings have to be flexible and adaptable, and agile is a good word too. I think, roughly speaking, our cost of our buildings and everything that goes with it is the plus or minus 5% of the total operation that of our OpEx. So it certainly can't be necessarily leading. It needs to be adapting to whatever's coming at us, whether it's telehealth or some other service line intervention thing we're talking about. In an inpatient setting, that's very costly. It's hard to plan around that in an expensive aging chassis that's got decades and decades of additions and modifications through the years, and 50-year-old boilers and things like that. And so I think our industry is moving towards outpatient in different forms, right? So whether it's an integrated care building that might be a little bit bigger and have a lot of specialties and ancillary services, or a surgery center, to something that looks like a single small point of care for a primary care access point. So now you start to have a much bigger footprint of care at home, telehealth, all of that. I think we can act and react appropriately. You don't want to get too far in front of your skis, right? So land is forever and buildings are for 50 plus years. We can't build something today that's going to, be a prediction of what 50 years from today looks like. So.
Good. Jeff, what about your perspective?
I thought about that question when you asked it, and I just jotted down something. I think for us 10 years from now, it's kind of three words. It's access, access, access. It's really about how to reach far greater percentages of the population at far less cost, because that's essentially at least the mission of CommonSpirit. And when we look at doing that, it means it's going to tread lighter, and you can read lighter to be less expensive. You can read lighter to be smaller footprints. You can read lighter to be shorter leases. You can read lighter to be far more technology enabled, and the ability to reach out and have far more virtual impact than we do even today. And I think we have the tech. It's improving every day. And one of the things we announced here a couple of weeks ago was simply Health at Home, another division of ours. We're doing far more remote monitoring for people at home. And that has exploded into the home acute care. It has exploded into literally the ability for support staff to contact someone being remotely monitored and say, hey, you should sit down before you fall down because you're about to pass out. Literally the ability, I think what we can do with the tech that we have as we explore it and expand it, talking more retail, more remote, more at home, more technology, and far more access.
Excellent insight. Really appreciate your sharing today.